This morning, one of our fellows in cardiology, Lindokuhle Qwabe, will be presenting on an approach to the diagnosis of acute coronary syndromes. And she'll be reviewing the current diagnostic criteria, which has actually changed over the years, how to interpret tests, including the ECG, and common pitfalls that may occur in the management of this condition. And this is really to avoid unnecessary delays in diagnosis and management, because as we say in cardiology, time is myocardium. So Lindo, let's start.
Okay, thank you, Dr. Patel. Good morning, everyone. Thank you for joining in. I'm Dr. Lindokuhle Qwabe. I'm currently the fellow rotating in cardiology. And so like Dr. Patel has said, we're gonna just go through the approach of acute coronary syndromes, just so that we avoid having patients that are referred to us with missed myocardial infarction, or just a confusion of how to diagnose and interpret the result, especially. So we're gonna go right into it. So just in terms of the basic approach and the basic classification of acute coronary syndrome, we know that there is non-ST elevation acute coronary syndrome, which we could be secondary to an NSTEMI or an unstable angina. And there is the obvious one, which is the ST elevation coronary syndrome. So how do we differentiate this? In terms of the ST elevation, usually there is obviously typical chest pain that can last more than 20 minutes. You have ST changes on the ECG, which the ST elevation is basically due to the transmural infarction, which is an infarction that is involving the whole of the myocardial thickness. And in terms of the non-ST elevation, is you do have ST changes, which you can have ST depression or T wave inversion, which are basically due to subendocardial infarction or tissue necrosis. And these patients will have a positive troponin, and they will present with typical chest pain. And the unstable angina is a patient that presents with chest pain, negative troponins, and they may and may not have changes on the ECG. So just knowing the basic classification just does guide in terms of how to further treat the patient. So this is just a basic classification. And then just quickly going through in terms of the chest pain and the symptoms and the clinical examination that you need to look for. So the patient will present with a substernal severe persistent pain, and the character of the pain is quite important, because it's not, it has to be actually differentiated from your other, your other differential diagnosis, such as your aortic dissection and pulmonary embolism. So this chest pain is quite dull, it's heavy, and it's pressure-like, and the patient will tell you that it does refer to either the shoulders, the arms, or the jaw. And it does have associated symptoms such as your sympathetic, which can be diaphoresis. The patient will be cool and clammy, and they might have palpitation or syncope. In terms of the parasympathetic effects, they have nausea, vomiting, and weakness. And importantly, there is an inflammatory response, which can have a mild fever in the initial period. So cardiac finding, so it's important to obviously examine your patient, just look if there is evidence of heart failure or systolic dysfunction, and clinically we'll be hearing for an S4 or an S3 gallop. And in terms of systolic murmurs, so you know that there can be mechanical complications, and importantly an acute myocardial regurgitation or a VSD, which we have seen quite a few since I've started cardiology, but this can be picked up clinically, and you can have a high index of suspicion once you've done your clinical examination. So in terms of reviewing the guidelines or the document that we're going to be reviewing is the 4th Universal Definition of Myocardial Infarction from 2018. So it is the European Society of Cardiology. So we're just going to be reviewing the definition of myocardial infarction. Then from that, we move on to the 2020 guidelines for an NSTEMI. So in terms of the universal definition of myocardial infarction, the criteria for it, it is clinically defined as the presence of acute myocardial injury detected by abnormal cardiac biomarkers. So this is highlighting the importance of those initial troponins that we have to do once the patient gets in, because that can indicate the myocardial injury, and in a patient who does have the symptoms that are suggestive of acute myocardial ischemia. And then you have criteria for a myocardial injury. So this is a detection of an elevated cardiac troponin value above the 99th percentile upper reference limit, and is defined as myocardial injury. So the injury is considered acute if there is a rise and fall in your cardiac troponins. And I'm sure you've actually heard the cardiology fellows or anyone you're referring to in cardiology asking for a repeat troponin level, because you want to see that acute rise and you want to see the persistent if there is chronic in terms of chronic myocardial injury. So it's quite important to have at least 3 sets of cardiac troponins. And then in terms of, we can have a myocardial injury from a cardiac procedural that is related to the procedures that we do. So that is defined as a cardiac troponin that is elevated more than the 99th percentile in patients with a normal baseline, or a rise in your troponin value for more than 20% from the baseline. And then this could be also more than the 99th percentile, but in a stable or in a falling or downward of the troponin level. So this illustration, basically, I just put it in just so that you can see the correlation between that on the time of onset of symptoms and your rise in your troponin levels. So if we look at this very the solid line that is purple, you can see that there is that initial rise in your troponin levels, and then, like we said, according to the definition, there must be a level that is more than 99 percentile, and then a slow decline in your level. But this can indicate an acute myocardial injury or myocardial infarction. Also to note that in the dashed line, blue lines, that and you can have persistently high levels, but within that are not hitting the 99 percentile level, which can actually indicate chronic myocardial injury. So you can always correlate the time of onset of your with the cardiac troponins. In terms of the spectrum of myocardial injury, it can range from patients that have no myocardial injury to a patient with myocardial infarction. So this basically shows us that if not every patient that has a rise in the cardiac myocardial troponin levels actually equates to a myocardial infarction. So there are other disease entities that we need to actually think of, such as the conditions that are noted in blue, where you get hypoxemia, anemia, your ventricular tachyarrhythmias, heart failure, your kidney diseases, and hypertension. All these diseases can cause no myocardial injury, but an increase in your troponin level. And where you have clinical evidence of an acute ischemic event, and you have an increase in your myocardial troponin levels, and that's where you suspect your acute myocardial infarction. So once we've done our cardiac troponin levels, we need to know firstly, what is our differential? What are we suspecting? Is it a myocardial injury related to an acute myocardial ischemia, or is there something else that can actually cause an increase in your cardiac troponins? So commonly the myocardial injury related to acute myocardial ischemia, that's where you have your atherosclerotic plaque disruption with thrombosis, and you can have your myocardial injury related to an acute myocardial ischemia because of an oxygen supply demand imbalance. So when you have a reduced myocardial perfusion, so commonly what we see is your patients that are presenting with coronary artery spasms or microvascular dysfunction, your coronary embolism, and your coronary artery dissection, your sustained Bradley arrhythmias, hypotension, and shock, and your patients who are in respiratory failure and severe anemia. And you have another entity where you have an increase in your myocardial oxygen demand. So patient with sustained tachyarrhythmia, severe hypertension, which could be with or without LV or left ventricular hypertrophy. And the other reasons for myocardial injury that we have to consider is cardiac conditions such as heart failure, myocarditis, any other cause of a cardiomyopathy, Takotsubo syndrome, coronary revascularization procedures or post-revasc procedures, your catheter ablations, defibrillator shocks, and cardiac contusions. So still the other conditions to consider is systemic conditions, your patients that are in ICU with severe sepsis, infectious diseases, patients with chronic kidney diseases, strokes or subarachnoid hemorrhages. As you can know, in patients that have intracranial pathology, it might be reflected as an acute myocardial ischemic event. So you do get ECG changes from an intracranial pathology. We need to be aware of that. Pulmonary embolism and pulmonary hypertension, infiltrative diseases such as your amyloidosis and sarcoidosis, your chemotherapeutic agents, and in patients, like I said, critically ill and patients that perform very strenuous exercises. So we need to be aware that all these conditions can cause a rise in your cardiac troponins, and actually classify once the patient you have the investigations or you have the cardiac troponins, you need to know what are the other concomitant or comorbid condition the patient has, and also what did the patient actually present with for you to actually do the cardiac troponins. Were you suspecting a STEMI, an NSTEMI, or an acute myocardial insult, or is there something else that could be the cause from the other conditions as we've mentioned? So in terms of myocardial, in terms of just interpreting your levels again, so once you have the elevated cardiac troponins and you have that one level that is more than 99 percentile, so you need to check if there is a troponin rise or fall, and if there is evidence of ischemia. So then if there is evidence of ischemia, you are suspecting an acute myocardial infarction. So in terms of the cause, it could be atherosclerosis or a thrombosis, or which is usually your type 1 myocardial infarction, or an oxygen supply demand, like we mentioned, from your type 2 myocardial infarction. Or if there is a rise or a fall without acute ischemia, but you are suspecting an acute myocardial injury, you think of the other causes such as acute heart failure, myocarditis, cardiomyopathies that we have mentioned. And if the troponin level is stable, and you are suspecting that there is chronic myocardial injury, so there are certain conditions like we need to think of, such as your chronic kidney diseases and your structural heart disease. And I'm sure when you're referring the patients to us in cardiology, it's quite important to note the renal function of the patient so that we know and we're able to track the rise of the troponin level. If the troponin level is remaining, it's not going more than 20% in the increase and the patient has a chronic kidney disease, it is most likely secondary to another cause or the kidney disease itself and not really the myocardial infarction. So it is quite important to note the rise and fall of your cardiac troponin. So just going through quickly the types of myocardial infarction. So type 1 is what we commonly see when you have the plug rupture erosions with occlusive thrombus, or you can have plug rupture erosion without or with non-occlusive thrombus. So there is a criteria also for this where it needs to be met. So in terms of the criteria, your patient needs to have a rise and a 4 or 4 in your cardiac troponins with at least one value that is more than the 99 percentile, and the patient must have one of the following. So the patient must have symptoms of acute myocardial ischemia. There must be new ischemic ECG changes, development of a pathological Q waves, and imaging evidence of a new loss of viable myocardium, or regional wall motion abnormalities that you can note from your echocardiogram that are consistent with ischemia. Or we can actually identify the coronary thrombus by angiography or post or intracoronary imaging or by autopsy. So your type 2 is, we have mentioned it, it's your patients who has oxygen supply demand imbalance. So they may have atherosclerosis with the oxygen supply demand imbalance. There might be vasospasms or coronary microvascular dysfunction, and non-atherosclerosis, coronary dissection, and oxygen demand imbalance alone. So these two are the most important types that I think as physicians that we can identify and actually be able to treat. So even with the type 2, there is a criteria for it, where you have to have an increase in your cardiac troponins, and there must be an evidence of an imbalance between your myocardial oxygen supply demand that is unrelated to coronary atherothrombosis. And the patients must have one of the following if they're also symptomatic, if there's new ECG changes that are suggestive of ischemia, if there's development of pathological Qwaves, and also if there is imaging evidence of loss of the viable myocardium. So what we mean also by that, if there's any thinning of your myocardium, and in terms of dyskinesia or akinesia when you are checking your echocardiogram, and if there is regional wall motion abnormalities that can be consistent with an ischemic etiology. So when you have a patient with a type 2 myocardial injury, you need to think of it in totality. You need to think, is there another cause that is causing the oxygen demand issue? What is the main reason for the patient to actually present? Did they have chest pain? Were they in cardiogenic shock? Was there another reason they presented to you? Then you have to look for the mechanism. So in terms of the oxygen supply demand imbalance, we've gone through it. So it's all the fixed coronary atherosclerosis, coronary spasms, embolization, severe hypertension. I would just like to highlight that because some of the patients from referral hospitals are actually thrombolized because of actually just severe hypertensive changes with severe LVH on ECG, which is a common mistake that we see, that we need to actually note how to differentiate between an acute myocardial ischemia from the severe hypertension, sustained tachyarrhythmias, severe bradyarrhythmias, and like we mentioned, anemia, hypotension, and respiratory failure. So I think type 1 and type 2 myocardial infarction are the most important that we need to be aware of. In terms of type 3, I will skip through type 3, type 4, and 5, because those are usually post-death or on autopsy, post-cardiac arrest, and patients that are post-procedural or post-CABG. So those patients will commonly be noted by cardiologists or cardiothoracic surgeons or by the ED guys when the patient is actually suffers a sudden cardiac death and there's no evidence. We have not taken any biomarkers to actually prove the myocardial infarction. So I'll just skip through the type 3, 4, and 5. And we'll just now go through how to actually assess ST segment elevation. So as you just noticed, is as a rhythm strip, or just highlighting the one where there is a sinus rhythm, because you can actually see the P waves. And what I just need you guys to note is how to actually assess for the ST elevation. So the first arrow actually indicates the onset of your Q waves. And then the second one indicates the onset of your ST segment or your J point. So the difference between these 2 points here, that's your ST elevation. And then there is different criteria for you to actually diagnose a patient with myocardial infarction depending on the level of the ST segment elevation. And just to go through the fact that every time you do an ECG, you need to indicate the territory that is involved in terms of, is it an inferior ischemia, is it anterior septal, an extensive inferior lateral, or whatever the territory that is involved, because it can indicate what artery you're anticipating to actually find as pathological or thrombosed or has plaque disease on angiography. So just for the registrars, just knowing how to measure your ST elevation and just know how to, the criteria for ST elevation for females and males. We'll still go through that now. So like I said, in terms of the ST elevation, so the patient has to have a new ST elevation at the J point. So the J points like we viewed on the previous screen, with 2 contiguous leads with the cut points of more than 1 millimeters in all leads other than V2 and V3, where the following cut points apply for males. More than 40 is 2 millimeters, and 2.5 millimeters in males less than 40. And for females, it's more than 1.5, regardless of the age. So it is quite important when you're interpreting the ECG, it is gender dependent and age dependent also. And in terms of your ST depression and your T wave changes, so you can have new horizontal or downsloping ST depression of more than 0.5 millimeters in 2 contiguous leads. You'll have T wave inversion of more than 1 millimeter in 2 contiguous leads with a prominent R wave or RS ratio of more than 1. Just to note that this is in the absence of left ventricular hypertrophy or bundle branch blocks. In terms of still going through the prior myocardial infarction evidence on the ECG, so you can have any Q waves in the leads V2, V3 that's not more than 0.02 seconds, or a QRS, a QS complex in V2 and V3. So your Q waves that are more than 0.03 seconds or more than 1 millimeter deep, or a QS complex in lead 1 to AVL, AVF, V4 to V6 in any 2 leads of contiguous leading grouping. And then you can have an R wave of more than 0.04 in V1 and V2, and RS, a ratio of more than 1 in concordant positive T wave in the absence of conduction abnormalities. So like we said, in LVH or a bundle branch. So it is important to just identify the Q waves. Like I said, also just territory of the myocardial that is involved on ECG. And it is also quite important to do your posterior leads if you are having a patient that is that you're suspecting posterior infarct for, so doing your V4 and then your V7 and 8. So we just need to know how to do those and interpret the ECG. So just still going through prior or silent unrecognized myocardial infarction criteria. So the criteria is anyone with the following criteria, if they have abnormal Q waves with or without symptoms in the absence of non-ischemic causes, if you have imaging evidence of loss of a viable myocardium in a pattern consistent with an ischemic etiology, or if you have a pathoanatomical finding of a prior myocardial infarction. Just other modalities in terms of being able to diagnose myocardial injury or myocardial ischemia. We have mentioned that the patients clinically and your history will indicate to you if there is an ischemic or ongoing process, and you do your ECG, we can do an echocardiogram, and we can do angiography from our cath lab. But also what you need to be aware of in places where there's no resource limitation is that we can do a cardiac MRI to actually show if there is any transmural subendocardial or any basically ischemic event, or if there is a non-ischemic event. So if we're doing an MRI, we're looking at the gadolinium-based contrast washout from the myocardium, which will show an increase in extracellular space, such as when you're getting fibrosis. So these areas basically are enhanced, and then these areas will be the ones that are showing the ischemia. So if you can look at the schematic representation that is on my left-hand side, you can see that there is that washout period here where you're getting that whiteness don't know if I can put it that way, which actually can show you that there is in this myocardial either transmural, which is involving the whole myocardium, or subendocardial, or just a focal subendocardial ischemia. So just what are the commandments that we are getting from this ESC guidelines? So we need to do our myocardial troponin levels, and we need to have that one level that is above the 99th percentile. The myocardial injury may be acute if you are seeing a rise or fall in your cardiac troponin. And then there might be also it might be increased in acute heart failure or chronic conditions if the rise is less than 20%, like we mentioned, as in chronic kidney diseases. There's myocardial injury may occur in a variety of situations, like we mentioned, post-procedural and other cardiovascular diseases, or even non-cardiovascular injuries or illnesses. And then occurrence of an acute myocardial injury in a setting of an acute myocardial ischemia defines an acute myocardial infarction. And then just noting the types of myocardial infarction, like I said, there's different types up to type 5, but we went through nicely type 1 and type 2 that we need to know, and just know the diagnosis or the criteria for each of the types of the myocardial infarction. Okay, so just moving on from the STEMIs, we're just going to go through just a short course of the 2020 ESC guidelines for imaging for non-acute coronary syndrome in patients presenting without a persistent ST elevation, so your NSTEMI patients. So I just highlighted this because of the difficulty in making the diagnosis of an NSTEMI, and the difficulties in referring a patient and actually identifying which patients need an urgent referral, which patients or what tools do we need to actually use to assess the severity of that cardiac event or the NSTEMI that we're having. So in terms of what's new and the new key recommendations from the guidelines, so in terms of invasive therapy, an early invasive strategy within 24 hours is recommended in patients with any of the following high-risk features. So if you do have a diagnosis of an NSTEMI, if you have dynamic or presumptively new contiguous ST or T wave segment changes suggesting ongoing ischemia, if you have a transient ST segment elevation, and if your gray score is more than 140. So I think we can all on MedCalc get the gray score. So when you're referring your patients with NSTEMI, you must have calculated your gray score, because then that is basically prognostic tool for us to know if the patient needs to go to cath lab within 24 hours as recommended by guidelines. And a selective invasive strategy for appropriate ischemic testing and detection of obstructive coronary artery diseases by coronary CT angiogram is recommended. So basically there are other tools except for just doing angiography. Just you can do a CT scan to actually in your patients that are considered low risk with obstructive coronary syndromes. So this guideline has changed from being taken from the guidelines of 2020-15. So I'll just note what has changed and not really go through what the 2015 guidelines said. So now we have a rule in, rule out protocol in terms of the sampling of your cardiac troponins from your 0 when the patient presents and 3 hour should be considered. And in terms of your high sensitivity troponins, so there is an algorithm that is now available for us to follow in the new guidelines. And the CT and the coronary CT is recommended as an alternative invasive angiography to exclude acute coronary syndromes when there is a low to intermediate likelihood of chronic arterial diseases or coronary artery diseases when the cardiac troponin or ECG are normal or inconclusive. And then in terms of monitoring your patients who have had an in-STEMI. So rhythm monitoring is actually recommended as a class 1 indication, type A evidence, for patients up to 24 hours or 2 PCI for any patient that is low risk of cardiac arrhythmias. And for more than 24 hours with patients with an in-STEMI, are recommended to be monitored for more than 24 hours if you are suspecting them to have a high risk of cardiac arrhythmias. So this schematic approach basically is just showing the diagnostic triage of your patients with an acute coronary syndrome. So your patients will present with clinical symptoms, and you just rate how, in terms of the chest pain, how likely it is to be cardiac or non-cardiac. And then you look at your ECG changes, and from ECG we mentioned that we can have normal ECG up to very significant ST segment elevation. And importantly, to do your initial presentation at 0 hours. So when you see the patient, cardiac enzymes, and also then you look at the repeat of your cardiac enzymes. So if a patient has no ECG changes and their enzymes are negative, you can rule out from your initial troponins, and then your changing troponins after 1 hour, 2 hours, or 3 hours. If those are negative, then the patient can be ruled out, and you can look for other causes of the chest pain or whatever the patient presented with. And also, just to rule in, if a patient has significant ST elevation, the enzymes are positive, or there is ST depression, and then your patient can be now ruled in as an in-STEMI and or a STEMI, depending on the ST changes on the ECG. So high sensitivity cardiac troponins, that's what's actually been emphasized quite on the new guidelines. So they have a higher diagnostic rate for an acute myocardial infarction. They do reduce the troponin blind interval, leading to an earlier detection of acute myocardial infarction. And it can result in a 4% absolute and a 20% relative increase in detection of your type 1 myocardial infarction, and a corresponding decrease in the diagnosis of an unstable angina. They are associated with a 2-fold increase in terms of detecting your type 2 myocardial infarction. And then in terms of the clinical implication of your high sensitivity cardiac troponins, so the level should be interpreted as quantitative marker of cardiomyocyte damage, and that is the higher the level, the greater the likelihood of it to be a myocardial infarction. So the elevation beyond 5-folds, the upper reference limit of, like we said, more than 99 centile for an acute type 1 myocardial infarction, then you can have an elevation of up to 3-folds the upper reference limit. It's only limited to 50 to 60% for an acute myocardial infarction, and may be associated with other broad spectrum conditions that we went through earlier. It is common to detect circulating levels of cardiac troponins in healthy individuals. So you don't need to do a cardiac markers if it's not indicated, because once you have positive results, then you have a dilemma where you can't interpret it because the patient did not really present with what you were, or you just randomly did bloods and it's not really indicated. So just noting the rising and the falling of your cardiac troponin levels differentiates an acute from chronic cardiomyocytes damage, like we showed earlier on. So this basically figure just shows us the comparison between your conventional assays in terms of your high sensitivity troponin levels to the new highly sensitive assays that we have. So you can see here they have a higher rate of picking up pathology, and they have a higher rate of picking up your type 1 myocardial ischemia. So it is quite important to have your high sensitivity troponins done on your patients. So we've gone through this, which is the other causes that you need to think of. So when you are suspecting a non-ST elevation myocardial infarction, so like I mentioned earlier, we need to do cardiac troponins at presentation at 0 hour and a repeat in 1 hour. So if those cardiac enzymes are negative, then you have a low index of suspicion to diagnose a myocardial infarction. So that patient can be ruled out and can be worked up for other causes, like we mentioned. Or if you have your high sensitivity troponin levels at 0 hour and a repeat, or if there is a change within an hour, then those patients need to be ruled in. We do prefer those patients to be discussed in terms of if you are needing a CCU bed or ward referral, the decision needs to be made by cardiology. And then they will be further investigated in terms of if they need an echocardiogram, an angiography, or stressing. But you do need to have the different types of your different hours of your cardiac troponins. So this is just basically going through what we've spoken about in terms of the cutoffs and the when to do your cardiac troponins, the importance of doing them at 0 hour and 1 hour in your patients with STEMI, just to apply your rule in and rule out algorithm. So in terms of the timing of the blood draw and the clinical decisions in terms of the European Society of Cardiology, so your patients with suspected myocardial infarction and you do your ECG. So we have mentioned that the blood sampling needs to be done within at presentation, basically when you see the patient within 0 hour. And you need, if you're able to get the result, then you'll be able to classify your patient. If not, then you do it 1 hour. And these are highly sensitive cardiac troponins that we are talking about. And then you will then, if the results are relevant, you can actually rule in the patient or rule out. But after that, you do need another third set, which is at 3 hours. And then you can just classify your patients in terms of if they're showing evidence of myocardial injury, or if you need to investigate for something else. So just importantly to note, it's 0 hour, 1 hour, and another repeat at 3 hours. So differentials of acute coronary syndromes, we have mentioned them just broadly. The classification is, it could be cardiac in nature, it could be pulmonary, so you could have vascular, important to differentiate your aortic dissection and diagnose it very early. It could be just gastrointestinal in terms of your patients with esophagitis, reflux spasms, patients with peptic ulcer diseases and gastritis. Or it could be just orthopedic in terms of just your musculoskeletal, your chest trauma, and your other psychological basically causes such as anxiety, anemia, and herpes zoster. So just always have an idea what are the differentials once the patient presents with chest pain that you need to be highly alert of. Just quickly, I'm going to go through, I know time is running out, but I'm just going to go through just highlighting in terms of when you get a patient, you've diagnosed them with a non-ST elevation, myocardial infarction, or myocardial injury. It is important to load your patient with your dual antiplatelet. So you can give aspirin loading dose of 150 to 300. And these patients, you need to ensure that there are no contraindication for giving the dual antiplatelet. And then you need to assess for the bleeding risk of the patient. So the current P2Y12 receptor inhibitors that we have is Plavix, which is your clopidogrel. So if you are referring a patient, the best thing to do is, and you've diagnosed them with likely a myocardial infarction or an STEMI, is to load them with your Plavix 300 to 600 orally, then you maintain them with 75 milligrams daily. And there's no specific adjustments in terms of in patients with renal dysfunction. So that is class 1 and class 1 level A evidence according to the guidelines. So I think we've gone through all of this, but just in summary, in terms of the management, we need to initially assess your patient, do your ECG and cardiac troponin. I know I've been repeating this, but it is quite important, and do the troponins at the different intervals as I've mentioned, and then refer your patients. If in terms of you have a diagnosis that you are unsure of, or you are considering other causes, you can do other cardiac biomarkers such as your pro-BNP, and also highlighting the importance of doing your GRACE risk score. And we've mentioned the additional ECGs where you have to check for in terms of your V3R, V4R, and just your posterior leads, also V7 to 9, if you are suspecting that you have a posterior infarct. So all these things need to be included in your initial investigation of the patient. So basically, just noting immediate the indications for immediate invasive management, so in less than 2 hours. So in your patients that have hemodynamic instability or cardiogenic shock, they need to be in cath lab within 2 hours. If you have recurrent or refractory chest pain, life-threatening arrhythmias, if you have mechanical complications of a myocardial infarction, like we mentioned, patients that can have VSDs or acute mitral regurgitation, if you have heart failure in the context of non-ST elevation myocardial infarction, or if you have ST segment depression of more than 1 millimeters, plus the ST elevation in AVR or in lead 1. So that's class 1C evidence. So those patients need to be within the cath lab within 2 hours, less than 2 hours. And for early invasive patients, like we mentioned, if you have a diagnosis of an NSTEMI, if you have dynamic new contiguous ST changes, if a patient has been resuscitated for cardiac arrest without ST elevation or cardiogenic shock, and just emphasizing again the GRACE score that we need to do. Then I won't go through the reversed modalities because then that will be more for cardiology. Yeah, thank you.